Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration.
Hi, I'm Jeff Rouse. I'm a prosthodontist with offices in Seattle and in San Antonio, and I want to thank my Seattle Study Club family, in particular Michael Cohen, for giving me the opportunity to present to you Moving Beyond Sleep Dentistry. For those clubs that haven't seen me, there is an evolution going on in dentistry, and the evolution is simply that we're taking concepts from the world of sleep dentistry, which was fabricating pieces of plastic that altered the airway. We're actually applying that to daily practice. So when I'm asked, how often do you do sleep in your practice? It's a very small percentage of the time. A different way of asking that question actually is, how much do you do airway? And how much do you evaluate airway? And the answer is 100% of the time. So what we're finding is a lot of the dental problems that we have thought were bacterially related or they were functionally related are in fact related to the fact the patient can't breathe very well, not only while they're asleep, but also during the day. Now the revolution that's actually occurred is actually in the last year. So Seattle study clubs that have seen me speak, within the last year things have changed quite dramatically. We've created what we call the Seattle Protocol. What the Seattle Protocol does is it tries to really focus in on individual patients and figure out what's required to fix that patient and control their disease rather than putting everyone into the same box. By doing that, it creates personalized control strategies, but more importantly, personalized strategies for resolution of the disease. Now, the old model was a model of sleep dentistry, and then that model, what we did was we had a physician recognize and score the disease. Then they would send us a letter saying make an appliance, and we would make that appliance, and we would protrude the jaw out, say 70% of what their maximum was. And we need to do that, and we can do that, but think about it. In that concept, we're dealing with people that are already sick. Well, see, what we're doing today is focusing on more than just apnea. We're focusing on airway types of problems. We're trying to be preventative in nature. So rather than deal with diseased people, which is what medicine does, it says you're diseased, now let's fix you. We're going to try to fix them before it ever becomes a problem. The other thing we're starting to recognize is they're incredibly poor compliance with these types of appliances. We might get half the patients to wear it for a year or two, but that number is going to drop off pretty significantly as the appliance starts to age. It controls the problem, but it doesn't resolve the problem, doesn't make them any better, it just holds them where they're at. It's about sleep, not airway, because anyone in this room that wore an appliance last night or used CPAP or should have done that, all of y'all are still having more difficult maintaining your airway sitting in the room right now. You're using more autonomic nervous system activity, more flight or fight reflex, just breathing today. And the last is, it's simply over-treatment. A lot of patients did not need that therapy, that's just what they got. And I'll show examples as we conclude. So, in the world of evolution, there are three main areas. The first is the problem is bigger than apnea. You know, we have a traditional model, and that model is that your tongue falls back into your airway, it closes off the soft palate, so you obstruct, you desaturate, you arouse, and then you take a breath. And that idea is still true in the diseased patient. But what we're finding more and more is that it's a breakdown of the system that occurs over time. It's about creation of inflammation and chronic stress. And in fact, what we figured out is the upper airway dilator muscles, as the airway begins to close, react independent of the brain telling it to do it. That's their job, to open the airway. So when in the very beginning of the process, the airway begins to shut down, your body reacts. Now, that seems like a good thing, that your body is keeping the airway open. The problem is you actually create inflammation. You create chronic stress in the system, and that's how your body starts breaking down. It leads to fatigue in premenopausal women. It leads to functional somatic syndromes like fibromyalgia, chronic fatigue, irritable bowel, migraine and tension type headaches, and eventually over time it's going to lead to hypertension. In other words, you don't wake up and go, last night for the first time I had apnea and I got high blood pressure today. You actually evolve into that situation. How do you evolve? You evolve through chronic stress and inflammation. This lecture could basically be about periodontal disease. It's exactly the same thing, and we're going to find in a minute those relationships. Inflammation in apneic patients is higher. Monitor their C-reactive protein levels, it will be significantly higher. Do it in upper airway resistance syndrome patients. Those young fit females whose airways are closing and they're fixing it, their inflammation levels will be higher. And do it in children, and exactly the same thing is true. Inflammation is what breaks down the system, and the number one reason for it happening is poor management of an airway. It leads to a chronic stress state in the system. Two things happen. Immediately, there is the activation of the autonomic nervous system. You get a fight or flight reflex, you release norepinephrine into the system. Secondarily, you leave yourself with higher cortisol levels. And cortisol, produced by stress, damages the system over time, a more chronic type of damage. So our body reacts to these little events. We call them inspiratory flow limited breathing. Not even close to an apneic event. And we're still damaging our body. Now, it's not just ours, our adult body, it's also children as well. Everything that happens in an adult happens in a kid. And in fact, the most famous sleep physician in the country says that you're not done treating children until you can get them to close their mouth and breathe through their nose all night long, and in fact, all day long as well. Only 2 times you ought to be breathing through your nose. The first is when you speak, and the second is when your exercise tolerance reaches a limit that you have to breathe through your mouth. The rest of the time should be nasal breathing. That's the healthy way to breathe. Third problem, evolution that's occurring. And that is we're going to focus on the real problem rather than what we would call a dental problem. Now, in doing treatment planning, you're going to have all these dental problems for your patient. You list them out. I'm going to suggest to you those are just signs and symptoms of what the real problem is. And the real problem is airway. So every time you make a list of dental problems, ask yourself, could this be an airway problem? And in fact, in all the areas you see here, they can. And it doesn't seem obvious. Bruxism, well, that one may be, but what about periodontal disease? It's the link from inflammation. What about caries rates? It's keeping your mouth opening and changing the oral cavity and the oral environment. All of those could actually be airway issues. So that brings us to the revolution that's occurred. And those of you, as I said, that haven't seen this in a while, haven't seen this part. The revolution that's occurring is that we're concentrating on nasal breathing. Now that seems weird for a dentist to actually talk about breathing through your nose, but in fact, it's the way that we've talked to patients for years. We've said, you're a mouth breather, therefore these are the problems. Unfortunately, we've never given them an answer. Now we know in the world of apnea that you're less apneic if you breathe through your nose. Something as simple as a decongestant will decrease your AHI or apnea-hypopnea index by about 12 points. It gets you to the right phases of sleep. It keeps you in those levels of sleep if you're breathing through your nose. So we need to concentrate on that. Unfortunately, our kids are breathing through their mouths. A lot of them are. And when they breathe through their mouths, they're not actually gaining the benefit of sleep. So we need to resolve that in children as well. So here's where the protocol comes in. It's one we've developed over the last year, and it begins with training people to breathe through their nose. Then it goes into different types of orthotics that dentists have used for years. For example, every one of you have made a night guard for a patient, and the patient came back and said, I can't sleep without this. It's awesome. Well, they weren't saying to you, thank God you got rid of that pesky second molar interference. What they were saying is, I can't sleep without it. You made me sleep better, breathe better. That's what appliances really do. So we're going to walk through 6 different iterations of solutions and see where the patient actually fixes themselves. First begins with nasal breathing therapy. And the idea is we're going to teach them how to clean their nose before they go to sleep. We're going to teach them techniques all day long in order to keep their mouth closed, breathe through their nose. But most importantly, we're going to use a piece of tape on their lips in order to remind them to keep their lips closed and breathe through their mouth. We're going to evaluate their ability to breathe through their nose, and we're going to teach them different ways that they're comfortable with in order to actually keep their mouth closed. Many different ways of making it happen, many different ways of propping the nose open. We're going to find the right technique for them. If that doesn't fix them, and interestingly it does in most of my patients, we're going to move to another appliance. This is a provisional appliance. You get it out of a bag and you start using it. The way that I began using it is as a true sleep appliance to titrate the jaw forward, but today we've changed. See, what we do today is we can warm it up and mold it for an arch, but we can actually just use the lower appliance and turn it into a night guard. So we pull it out of a box, warm it, put it over the teeth, and it becomes a lower night guard for us, and we use a piece of tape on their lips. What did we just do? By opening the vertical dimension, we open the amount of oral cavity volume they have. If their body says, I love that, I'll take advantage of it, I'll get my tongue out of my airway, then they're going to sleep better. They're going to come back after a couple of days and say, that's perfect, I love it. If that solution doesn't work, we're going to add some soft beads to the appliance. We're going to have them protrude forward a couple of 3 millimeters. That's called an anterior repositioning appliance. You know that appliance because we've been using it in dentistry since the 1960s. I've just got a way of fabricating it chairside for you. We'll see that protrusion forward can fix a lot of patients as well. That's why studies of over 3,000 patients wearing anterior repositioning appliances said they got better. It's because they slept better, they breathed better, their inflammation went down, and their chronic stress went away as well. So if that doesn't work, we have 3 different versions of using a twofold appliance. One with no protrusion, one with slight amount of protrusion, and finally we get to what we would traditionally call the sleep appliance, where the jaw is moved out a significant amount of the way. You see, we're trying to figure out where your patient is fixed rather than make everyone fit into the box of sleep dentistry. So what does it do? The Seattle protocol makes sure that they're comfortable wearing the appliance, that it doesn't hurt them to wear the appliance, and it fixes the problem before we ever make them a final appliance. Because at whatever step they are that they say, I'm better, I make a final version of that to control their disease. Because the goal here is to prevent the disease if at all possible, to control it for sure, but my next goal is I want to make it better. I want to use it as a clue to tell me what I need to do to actually fix the problem. I don't want to just leave you there with a piece of plastic. And that's the next step. Let me give you an example, real simple example. What if I put a piece of tape on my lips and after 14 days they say I can't wear that? I just can't do it. Well, the referral is pretty obvious. The reason you're not sleeping well is because you're not breathing through your nose, and if you can't breathe through your nose, you need to go to an ENT and figure out why and make it better. What if I put a piece of tape on their mouth and they fix themselves? There are 3 studies out in the ENT literature that says that that is possible. Well, what they're saying is there's a small blockage point in my airway that the tape overcomes and keeps my mouth closed, because a 10% reduction in flow will cause my mouth to pop open. So what do you do with those? Well, let me give you kind of a backwards example of this. This is a patient that was referred to me about 6.5 years ago. She was referred from a sleep physician that said, make an oral appliance. I made the traditional appliance. I moved their jaw a long way forward and held them there. She had an RDI of 14. That kind of puts her at the mild to moderate level of apnea. Now, when I did that traditional appliance, I got her apnea level to drop to 2 and her RERAs, or small events, to drop to 4. That was then validated by a physician. She wore that appliance. Unfortunately, along the way, her general dentist removed an ortho wire on her lower teeth. Well, my appliance was made to that wire. So the teeth started shifting. She asked for another appliance. She didn't care for the other appliance. She came back to me and said, make the appliance you made me the first time around. I said, well, I've been through a revolution since I visited with you last. We got to do a little different. We have to start and walk through my protocol, because no one gets to skip this protocol. Step 1, we're going to teach you to breathe through your nose better. So we sent her home with a piece of tape. We taught her how to actually breathe through her nose more efficiently. She said, I feel better. We tested her again, and I'm 50% better than what I was able to gain with an appliance that jutted her jaw out a mile. All she needed all along was to be able to breathe through her nose. She didn't need the piece of plastic. So now what does she have to go through? Well, unfortunately, her teeth have moved and her bite has changed, so she's got to get that resolved orthodontically. But she also is telling me, really all I need to do is have my nose fixed. My nose collapses and I have some issues with it. Just fix that and I'm done. So what I'm going to urge you to do is begin to really focus not only on sleep dentistry, but really focus on the airway and begin treating your patients, not just their teeth. Thank you.